Everybody. Hi, everybody. Here I am going live in my once a month Wednesday 4:30 talk. It's great to be here with everybody. Hopefully, I can get everything straight in my head. I've got a lot to say about birth and all of that stuff. So, the first thing I wanted to do though when I start this talk, so first of all, let me tell you that I've moved my practice to the school. So here I am instead of being at my house looking out at the beautiful trees. I'm here at school, but the great part is that behind me we get to use the whiteboard and all the bones that are here, which is super fun. But one thing I want to talk about, or just say first off, when we start this talk about birth and symptoms and trauma and stuff like that, is moms, all of you moms out there, I really want to put a disclaimer, not a disclaimer out, but a thing that says you did your best. You did, look, I got goosebumps even saying that to you. You did your best. You did your best for you and your baby, and you followed what you needed to follow, and your baby is here. So I really want to start out by saying that, it's going to be bringing up feelings, not for every mom, but for many of the moms out there. But you did your best, and I want to say that to you. So now we're going to go into all of the different things that are involved. So when I thought about talking about birth and birth trauma and the symptoms that come out of it, which is just like super interesting, I am going to share that. But I do want you to know that I'm going to start off with mom and mom's body. And the deal is that baby is always taking position from mom's body. So, I've had women say the baby did this to me. And actually, it is really because of mom's body and pelvic structure position, mom's health, her pelvic health, her congestion, whatever, is really dictating the baby's positions and the baby's ability to get out and all of that. So let's start off with normal shaped pelvis. Let's do that. And actually, let me show a picture that shows you that there are different pelvic shapes, whoopsie, for the female. So you have the pelvic shape here, this one, that is more of the normal and rounded pelvic shape. And then we have the pelvic shape where the mother is wider and more oval. And then look at this one. This is a heart-shaped pelvis shape, and this is a, sort of an oval going from the back to the front. Now, one of the things is it's harder to get a baby out in an oval-shaped pelvis like this oval shape. Well, here's the really sad part, you guys, is that when the doctor lays you down on your back or puts you posterior in order for you to have during the birthing process, one of the things that happens is the pelvis will take on this shape. It will take on that more, instead of the round shape, it takes on a longer, more oval shape. And it's more difficult because what the baby does, let's get this back up here, because what the baby does is when they're coming out, it's easier for them to come out in a bit of an oval shaped from side to side than it is from front to back, because they're turning their head sideways in order for them to get out. So the baby has a couple of turns down going through the birth canal. There's actually 2/4 turns, but trying to get out from this one is very difficult, and the baby excuse me, and the baby often gets stuck. But let's add to the fact that, say a woman falls on her tailbone. So I'm so happy to have my whiteboard behind me. So let me draw something and make sure that I've got it so that you can see it. So here we have the circle of the pelvis, right? So we have this circle. Maybe I'll use black. I think it'll be easier to see. And here we have the sacrum, right? This is the back and the back side. These are the pubic bones, right, in here in the front. So what happens when I fall on my tailbone is that the shape of my pelvis then becomes more shorter front to back. Once again, that is creating a very difficult way for the baby to come out. When this tailbone fall or whatever happens, right? and I'm locked more into this, that has a tendency to create more back labor, a lot more back labor in women, and that's painful. And even sometimes what this will create is a baby that is actually what they call sunny side up, which is the face of the baby should, when it's going down the birth canal, when it's going down, the face of the baby should always be facing the back, not the pubic bones. So, but what happens is mother's position will oftentimes, the pelvic shape will oftentimes change, and it will create the baby coming out with their face towards the front. Now that is very difficult for both the baby and can be difficult for mom. And what happens is it does give mom more back pain. It gives her more back labor. So with giving mom more back labor like that, she's going to need a little, oftentimes needs a little more intervention of epidurals or whatever as the back labor is going on from the tailbone fall. So one of the things I also want to show you is in here, this is a picture. This is a picture of a female pelvis, right? And what's happening here is this is mom, let me get in the right place. Yes, this is mom's bladder. Here is mom's uterus coming right here over the bladder. Now you can see why you have to pee all the time, can't you? Because that uterus is right over the bladder. Here in the back is the bowel, and this is the sacrum, the bone at the bottom, at the back, okay? So we have bladder, then we have uterus, then we have bowel, right in a line there, okay? So let's talk about some things about the uterus and being in positions within the midst of the pelvis. So here's the deal. This is a great picture. This one, whoop, let me get it in here. So what we've got here is this is the front of mom. These are the pubic bones. Right here is the bladder, right? We have the uterus, and then we have that brown looking bowel in the back. Now, what I want to show you is that which one is normal position is the tan one that's sitting over the uterus. All you have to do is have a fall. That's all you got to do. You got to have a fall on your tailbone or your bum or something. And what can happen, and I have to tell you, this is so common, you guys. And one of the things that they will tell you is that, like at your doctor or the gynecologist will tell you you have a tilted uterus. Well, what does that really mean? Because you can have a tilted uterus in a lot of positions. So what happens here is going from normal, this is normal, if I fall on my tailbone back here, I can flip my uterus into any degree of, of a tilt, they call it tilted. It's actually called retroversion, where it starts to go retro, it starts to go towards the back. So you can have a uterus that comes here and is a little more vertical. You can have a uterus that gets even more vertical. You can have a uterus that goes all the way and is laying back against the bowel. And what you can also have, let me draw this because this is kind of interesting, is that you can have a uterus. So here's my bladder over here, guys, and here was where my uterus should be. And I can have a uterus that does this. I have felt that on women, and there's the vagina, is here, is that it's flipped all the way backwards. Let me share something with you about these uteruses that are more retroverted into these different positions. It is much more difficult to get your baby out. You want to talk about some back labor. That is some back labor going on there when the uterus is tilted like this. It has well, okay, so the uterus is tilted. These women are the women that have a tendency to have really long, heavy periods. So you have long and heavy periods. You have, and as you get older, you have a tendency to get more clotting in your periods. These are the women that often end up with, that actually often end up with hysterectomies, because these are the women that tend to get more fibroids, they tend to get more clotting, they tend to get a lot of things that are more difficult with these uteruses that have actually gone into these different positions of being more vertical to being all the way backwards. So women like this, prior to having a baby, if you have a super heavy period, I'm giving you the clue on the super heavy period that tells you go to find somebody who does some kind of internal work that will help you move your uterus back into place. There are people that actually do that, and I would suggest it because not only is it going to help you to allow you to birth your baby more normally, a little more easily, but it will also help you in your life in the long run. This is like in your life in the long run. So we really want you to know that that can happen. Now, I want to talk again about the bones for just a couple of minutes here because one of the things that's super common, I'll do it with this picture. One of the things that's super common, we don't care which one we're looking at, okay, is for a woman to actually get hit in some way in her lifetime on her pubic bones. So let me sort of get that a little more established. So I know that I did. I fell on my bicycle so that I fell on my bicycle like this. And what that does is it completely locks up the pubic bones. So I don't care how much relaxin, the hormone to help you have your baby, is coming out. What's happening is if my pubic bones are locked, or one side, one pubic bone is locked, then that won't open. So when that doesn't open, what happens is that you have either one side opening or neither, and so therefore you're either going to tear or that baby is going to end up being into a more of an emergency C-section. So we've got that going on as well, is that the bones of my pelvis, not only do I want them to be round, not only do I want the pelvis to be the correct shape, but I also need to have my pelvis so that it has the ability to make the movement to open. And I have to tell you that in my personal opinion, my personal opinion is that more women have trouble having their babies because of some kind of like fall or injury, even when they were very, very small, that created a locking or an immobility within the pelvic bones themselves. The other thing is that each of the side of the pelvis, right? You have your pelvis. Look at this guy. So I have two pelvis bones together with the sacrum that makes the whole pelvic girdle, that makes this girdle. So here's one, here's two, and here's my sacrum, and they meet and make those SI joints. Now, each one moves independently of the other, okay, with these two sacrum in the middle. So they move independently. So think about how common it is to get one side of the pelvis to actually be in some kind of a rotation or some kind of a pattern. When that happens, and I actually have a picture, you guys, is that when that happens, when the pelvises are misaligned, which is super common, like off the charts common, it's super common when the pelvises are misaligned, that the pelvises are doing two different things, the two ilium. So the pelvis itself and the two ilium are doing different things. So let me show you. I want to erase this and draw a picture. I want to erase this. And I want to say that I'll represent my iliums like this. Here's one and here's the other. So I can have one that's actually gone too far down or too far up or in a rotation. When that happens, my whole pelvis changes shape. And what happens, oh my gosh, this is super common, is that the child will get something called plagiocephaly, which what that means is, it's not as bad as it sounds, but it's not as great as it sounds either, is that the head actually goes into a parallelogram. Can you see that? They've even drawn the parallelogram that happens. So what it looks like on the baby is that one side of the face is more pronounced than the other, and it's the same in the back. And here it's showing you on the back how flat the back becomes. What do? They tend to put a helmet on to try to get the shaping back. And the piece about this is that oftentimes isn't like thought about is, mom, if you have a baby that's head comes out with a different shape like that, that's your pelvis shape. So when you go to have another baby, or you go to, you have a friend that goes to have another baby, you want to share with them, correct your pelvis before you get pregnant next time so that the baby is not taking on the same shape of as your pelvis. So we really, that's a super, super important piece here, is that the baby will definitely take on the shape of your pelvis. And I don't think that many people actually think about mom and the preparation for mom to get ready to get pregnant. Most people are coming and having back pain while they're pregnant and many things like that that really could have gotten eased and had a much easier pregnancy if mom was actually ready. Okay, so now let's go on past mom's pelvis and let's talk about the different births that there are. So one of the things that's kind of interesting is that I've been studying birth styles and their symptoms since, the mid 90s. Probably in 1994, 95, I was off, doing workshops on what happens to babies and how do you work it with both cranial sacral work that I do and so forth. So it's an interesting field, and it was stunning to me when I first started learning about this. So what the different birth styles do. So, and you can also see, it's really interesting because you can also see in decades, the changes over the decades of the different styles and what it is that's come out in sort of a generalized symptomology within different generations. So, for example, in the 1940s, when they were giving mom ether and knocking her out, so they're knocking mom out and then they're taking the babies most of the time with forceps, pulling the babies out. You have these children who they're okay. So I'll talk about the children in a second, because what I do want to say about birth is that the actual process of birth is nature's way to teach you how to deal with problem solving and stress, what you do under stress. That is, I think that's kind of cool, that is nature's way of teaching you how to problem solve and how to actually work through something, but also how you do it when you're under stress, right? Because it's a stressful situation, isn't it? So the deal with that is that depending upon what interventions are used, or what is happening in the four different stages, is what will bring the symptoms on. So here you have mom being given ether during during this important time for this baby, and mom is either in a sort of a zone or knocked out. Okay, so isn't it interesting that that happens in the 40s, and when that generation, this is me saying this part, is that generation from the 40s gets to be old enough, the late 40s and early 50s, when they're doing this, is when that generation gets old enough to hit that place between, almost adulthood, like 17, 18, 19. Did not the 60s have the whole generation that went in and was starting to do those drugs that made them floaty and all of that stuff? I mean, you can really see it. So if you ask yourself now, what is the difference? So what is the drug that then came in the later 50s and is still used today? And we'll talk about the difference of how it's being used today. Is you have much more people with, you have Pitocin to induce, to make an induction, is that you have a lot more people with a lot more Revy quality to them. So let's talk about this. So, so we had the ether going on in the 40s, and then in the mid 50s, they figure out, however, they came out with the Pitocin. And oh my gosh, what I've learned lately about how birth really works is so friggin' interesting. Is that, so I've always understood that, or thought that the uterus contracted in order to get the baby out. But I have since learned, because I was doing this talk that it's actually, that's not how it works. Is, let me show you something. I got to show you this. You'll love this. Is, or I love this, so I don't know if you'll love this, but I do. Is this, is you have your uterus. Here's the uterus if we were looking straight on to your uterus. So here's the uterus like this, right? Here's the uterus. And what's super interesting is connecting inside this part of your hip. So inside this part of your hip, remember that when I show you this, there is a ligament that looks like a sail that connects to that inside of the hip from the uterus. So each side of the uterus has this that looks like a big sail. And here's the thing, it's called the broad ligament. And that ligament actually is what is, there's blood source into the ligaments. There are blood vessels in the ligaments. And it is a hydraulic pressure that does this. It does not, your uterus does not contract. It is these broad ligaments using hydraulic pressure that actually gets the, pressure on the uterus that actually starts to track the baby through. I was like, whoa. Okay, that was just me personally. So anyway, but this changes everything because here's the deal. Why do I tell you this? And every time the baby moves down and this hydraulic pressure happening here and the baby moves down, the uterus also moves down and doesn't let itself retract back up. So it compresses and brings it down as the baby is going down. How freaking interesting is that? Okay, so I love this stuff. I was put here for this stuff. So here's the other piece, Pitocin. So when Pitocin came on board, okay, what Pitocin does is contract your uterus. And your Pitocin contracts your uterus longer than the hydraulic pressure contracts your these broad ligaments, these big sail-like ligaments. So my uterus is contracting for longer than it is that a normal contraction happens anyway. So what happens is that is what ends up putting like, how do I want to say this, is creating the scenario where the baby goes into distress because the contraction was not on the baby in the first place, which was like, oh, I mean, I like loved this yesterday. It was like, not yesterday, the other day when I read it, I was like, oh my gosh, the contraction is never on the baby in the first place. The contraction is actually coming on the sides. But when you put Pitocin in, Pitocin makes the contraction that's happening on the uterus that makes the baby's heart rate start to drop, which is why we end up with all of these emergency C-sections. You got this? So Pitocin over the years, one of the other things that happens with Pitocin is that it starts the adrenal glands of both mom and baby to be active. So the adrenal glands are going with the Pitocin in there, okay? So we have that as well that's actually happening, is that the adrenal glands are now firing of mom and baby. So baby's under stress before it even gets out. Say that again. The baby is under stress before it even gets out. So Pitocin is something that doctors actually act like should be the natural course of what you do when somebody's giving birth. And I personally don't agree with that. With all the years of study that I've done, is that many mothers are doing just fine by themselves. But part of the problem is, as I said in the beginning, is when they lay mothers down, mothers, as soon as they lay them down and they put them on their backs, then you've got the wrong direction, not just from a gravity standpoint, but from the standpoint of how a baby should actually traverse down. The best position is when the mother is, sort of either on her feet or on a bit of hands and knees, but she's a little higher in the front, she's forward, okay, and the curve in her low back is out. So that's the best thing that she can do, is actually make sure that the curve of her spine, the lower back, is actually is going a little more backwards, not arching, but the opposite direction, rounding. And that creates a straighter tube for the baby to come through. So now we have this Pitocin contracting the uterus so much that we have all these emergency C-sections, because what's happening is that just because the uterus is contracting, it is not the hormone that actually opens the cervix. So the uterus is contracting, but it's not the hormone that's opening the cervix. So the dilation is not dependent or in relation to the Pitocin that's actually going on. So let's extrapolate or bring it to more like in the last 5 to 10 years that what's happening. So the Pitocin before was part of the birth process that the doctors were adding in. But now the doctors are kind of scaring a lot of women into having, afraid that it's more than 2 days overdue, or the baby is too big, or something along those lines. The mother should be able to get the baby out no matter what, even if she's small and it's a 10-pound baby. If all the ligaments and all of the, there's no bone stuck like I described earlier, like locked up in the pubic bones. If that's not happening, she should still be able to get, without tearing, get a 10-pound baby out. But now what's happening with these fear things that are being added, and I'm so sorry, moms and new moms and moms of old moms, is that the other piece of this is that they are now doing induction when you're not in labor. And the horrible part about induction when you're not in labor is that the fluid that's in the uterus is now acting on the baby. It's actually, with the induction, it's just compressing on the baby and creating babies with sensory integration issues. And how many people have children that have more sensory integration issues and more Asperger's like symptoms are often coming from this scenario, this kind of scenario. So, so wait till you're in labor. Wait until you're in labor before, all this stuff gets introduced. I mean, also, in my own opinion, because everything is my opinion right here that I'm talking about, well, my opinion, a lot of years of study, but is that, you know, um, I forgot what my opinion was. Oh well, I'll get back to it. So, you really want to be in labor, which will take me over from the place of emergency C-section, from the contraction that I'm talking about, from also having an induction when you're not in labor, which creates all of these problems. But the other thing we want to talk about is actually, once you are in labor and you're trying to have your baby, and say the baby gets stuck. Okay, this is the part that I just want to say to you moms, that any of you women, is that I'm so sorry, and I'm going to show the forceps and also show what it does on a baby. I hope that I don't make you uncomfortable. I'm also going to show you what to do with suction. So this is a picture right here of forceps right up here. So this is forceps that actually looks like, a pair of tongs on either side. Now here in this one, the forceps, they're showing you the forceps come around and goes around the ears of the baby on either side, right? But rarely do they get it so that it is actually centered correctly. It should be around the ear like this, but many times the forceps are more forward. And here's a picture of a baby that you can even see the bruising that happened from the forceps on him. And look at this, whoopsie, look at that baby at birth. How much the squeeze happened that changed the face of this poor baby's head. Now, can you correct that with somebody working really early, doing some cranial sacral and some osteopathic manipulation? Yes, you can actually help a bunch of that and help that to mold and come out a little bit better. But that's forceps, okay? And that and then, I'm so sorry for everybody, but here we go. This is this is the vacuum. They show where they're pulling with a vacuum. So they're vacuuming the baby out, but look at, this mother is laying on her back. She's laying on her back. This is not a good position for this baby. So I'm so sorry to show you that this is the shape of the head from the vacuum. This is what the shape of the head looks like. In a vacuum birth, and I'm losing people because this is making them uncomfortable, I'm so sorry. But in a vacuum birth, one of the things that happens is we have fluid in our brain, not only circulating around the brain, but we have fluid in different parts of our brain. And what happens on the vacuum is the vacuum pulls the fluids, actually pulls the fluids out of the spaces where they're actually supposed to be. And so what happens is you get sort of a the trauma goes into kind of like a really sensory. Oftentimes you'll see babies who have had the suction really big. What will happen is that their eyes will do nystagmus, which is, I can't do it, but it's where the eyes really rotate from back and forth and back and forth. The other thing is these are many of the children with the vacuum or a high trauma is also where they will also have these silent seizures, or maybe not so silent, where you see your child or the baby staring off for seconds or 30 seconds at a time. Those should be checked out by a doctor, and you most likely are having a child that's having what sometimes they're silent, sometimes they're not, the silent seizures that are happening to these babies. So we also have, and then we'll talk about a little bit more symptoms, is we also have the baby that looks, wow, doesn't that baby look great? That baby was a C-section, a planned C-section. That baby looks great. So now let's talk about the symptoms. So a planned C-section baby sounds great, doesn't it? It's like planned, head doesn't have to go through all of this. That isn't going to have to happen. But really what does happen is that there's a reason for going through that birth canal. There's a reason for that molding that happens that also gives you a sense of yourself. That's one thing that it does. Besides giving you the bacteria and your setup for your own gut through your mom's gut going through. There's so many things about going through that are important. So if I'm in a planned C-section, so here I am all perfect and everything like that. But what happens is a couple of things. One is when they cut in on a planned C-section, 2,000 pounds of pressure per square inch, boom, hits your baby. And the baby's in shock. Because a lot of times people with those planned C-section babies say, oh, my baby's so good, hardly ever cries, sleeps all the time. I have to wake it up to actually feed. But actually, what's happening is that poor baby's in shock, right? So you've got a baby that's more in shock. And when I treat those babies, I say to the parents, okay, here goes, because once I treat your baby's going to come back into its like, and so it's going to probably cry more like a normal baby should, as opposed to a baby you have to wake up or is so passive. So that's one of the things that happens. But also with the planned C-section is you also get, now, I don't want to say this is absolute, but I just want to say these are tendencies in style of personality, is because they didn't get to go through their stages of birth. These are the guys that really are kind of lost, don't know how to start a project, don't know how to get through something, to work through the levels of a project. These planned C-section babies are kind of at a loss as to how to get engaged into something because they never did. They never did. So you have the emergency C-section, which leaves a baby with a lot of trauma into the head, lots and lots of trauma that way. And then you have the planned C-section, which gives an overall shock on the system. And they're very different because the symptoms on the emergency C-section person will have a tendency to be someone who is more intense, really hyper, the kids that can't listen, can't sit down, their whole systems are jacked. Quite often they're constipated, quite often they can't sleep. As children, as babies, they might cry all the time. You cannot seem to settle them. That's because there is an irritation in the nervous system because they were trying to get out and trying to get out and trying to get out, and so it makes it incredibly difficult. So so there, then we have, of course, we said the planned C-section, we said the emergency C-section, and I made reference to the Pitocin. It definitely, especially if the person is not in labor, you tend to have a child that's much more sensory integrate, has many more sensory integration issues. And then you have the regular, a birth that's considered regular, that so woman is in labor, she's giving birth, they give an epidural, and what that does is the epidural stops the process. So now the baby, like as a more adult person, what happens is like, yes, I'm going and I'm doing what I'm doing my project, I'm doing my project, and I can't get finished. I can never seem to finish anything. How come I can't seem to finish something? And part of that is because of this piece, is the piece that you didn't get to finish. I mean, when the epidural came, and you got floaty too, because the epidural's not just hitting mom. None of these drugs or these interventions just go to mom. They're going to you as the child as well. So that is one of the big things that happens with an epidural. It's like I have forward momentum, and then all of a sudden that's like cut and stopped. And then we have, um, one of the deals about all these traumas that we all carry, and because everybody comes in with birth trauma. I'm sorry. It's just the name of the game. It's the name of the nature of the beast, how, that we have birth trauma. The problem is that we've medicalized ones a little too much more than we actually really needed. So some of the symptoms from birth trauma, besides all the sensory stuff that I'm talking about, are things like constipation, things like sleep is interrupted. You can have a child that's really shy and worries a lot and is just sort of inside themselves, and you can have the opposite being true, where you have a child that's so aggressive and can never sit down and can't focus. These are all birth trauma things, and the earlier you get your child to someone who knows how to work on them, although there's few of us and far between. Sometimes I just wonder if I should have a morning for newborns, having people bring their newborns here, is that it makes such a difference to really go with this stuff. So I'm going to leave you with one more piece of information, like I haven't given you enough already, but one more really interesting piece of information. And that is, so this is a picture of a birth of a star. And here's the interesting thing about that eruption is that, did you know, and it's called, I have goosebumps telling you this already, is that you have two, what they call, it's called, one of my teachers called it ignition, and I've read about it, and it's called awakening, that there are actually two ignitions into life. And the first ignition is conception. So that first ignition, when you get ignited into life, is conception. How cool is that? How cool is that? And then the second ignition is your birth. That second ignition into life is that birth, coming through the birth canal and then taking that first breath. And the problem is that we are really, really, I'm going to say it this way, screwing with how that second ignition is happening. And that is just, I can't even say how problematic that is that coming into life. So I had a little guy, how old was he, 7 or 8 or something, and he came and laid on my table, and I forget what the reason why, mom, he had all of the constipation and he had all of the typical symptoms that you have. And I put my hands on him, and what I felt was the life force in this little boy was so muted, so muted. It was so interesting. And so actually the sad part now that I think about it is mom did not bring him back, but I would have worked on getting that spark of life to happen, getting that ignition to really come in so that he could really come fully into life, because he'll always be like he's behind some kind of a curtain or something. So anyway, just some views on birth, and there's like I could probably talk about this for 4 hours, but I won't because I love you all. And thank you so much for joining me. And if you have any ideas, please, 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 this was somebody's question to me. That's why I talked about birth this time. So if you have any thoughts or anything you're interested in that I could actually translate into sharing information, I'd be more than happy. Thanks for hanging out with me, and you guys are great. See you next month.